Health plans are putting a lot of focus certainly on the multiple sclerosis category due to the number of newer brands coming to market and quite different products with dosing schedules that are a bit unusual. So they are promoting preferred brands. Certainly generic step edits are a possibility now that we have generic glutaramine acetate. And also outcomes contracting is at play to try to manage some of these new branded agents that are coming through the pipeline. Some of the newer branded agents at very high cost and agents with novel dosing schedules and long-term efficacy are certainly challenging for health plans to manage. Drugs like alemtuzumab and cladribine that are dosed on a 2-week schedule each year, and then there's no dosing the following 2 years, certainly make for a very interesting opportunity. So you're paying for the drug up front, so to speak, and then you might get 4 years' worth of efficacy, despite only 2 years' worth of dosing. Well, certainly annualized relapse rate is the most familiar of the outcomes that we've seen over the years in most of the clinical trials, would certainly be something we can measure. Also, a T2-weighted MRI to detect T2 lesions and gadolinium-enhancing lesions to detect age of the lesions are better markers of disease activity. However, it's not something that plans are going to promote to have patients subject to an MRI on a regular basis. In addition, any type of adherence approach to treatment would also be valid outcome measures that could determine whether or not a patient is responding, with the expectation if the patient goes off the drug or switches to another drug that there is a negative outcome at play. Any programs that focus on compliance, help patients manage side effects are certainly going to be viewed favorably. We clearly want these patients to use the drugs on schedule as prescribed so that we get the maximum value clinically in return for our investment on these drugs. Well, clearly support of our formulary choices when they're appropriate is quite helpful. We try to select products based on efficacy, safety, tolerability, and cost. We're trying to balance a very broad specialty marketplace that includes the MS drugs, and disease education for the patients as well, so they understand how to take the drugs, when to take them, so that they maximize that clinical return on these agents and really understand the disease and what may trigger relapses or what may cause some of these drugs to fail to deliver on the clinical promise. Well, we always say that we like copay assistance programs when we have the drugs preferred on formulary, and we don't like them when the drugs are non-preferred or non-formulary. But that being said, it certainly impacts the patients where they have high out-of-pocket costs or deductibles or coinsurance that's high, and clearly can provide a benefit to patients on the copay assistance side. With the accumulator programs, it's a little bit of a different story. There is a mixed opinion on that in the marketplace. Some plans believe that the accumulator programs are not appropriate and don't really line up with the requirements of the ACA, and then others are using these programs which essentially don't allow the assistance to apply to the patient's out-of-pocket coinsurance deductibles. And I think the jury is out, so to speak, on that one as to whether or not those will continue, but they can be quite challenging to a patient if now all of a sudden they've got to account for this high out-of-pocket cost on their own without any assistance being applied. We're certainly seeing a shift in focus on the value of pharmaceuticals and not simply how much of a rebate we can negotiate or what the rebate might look like. Certainly rebates are still a critical part of the finances across multiple plans, commercial, Medicare, Medicaid. Talk in Washington about rebates maybe going away certainly gets people excited. You know, it's not necessarily a bad thing, but it needs to be balanced because they are fully integrated into the finances of a lot of these programs and services. That being said, certainly value-based contracting takes a different approach to try to get good return on investment for these products as opposed to simply a straightforward rebate. Well, certainly adherence to therapy is a common one, or switching, as I mentioned earlier. Annualized relapse rate as measured by hospital activity or emergency room visits, and the use of high-dose steroids, or ACTH, are ones that would also imply that the patient had some type of relapse that was treated with a steroid or ACTH. Certainly, ICER has some interesting financial analyses on particular products, and in some cases, pre-launch, they give manufacturers direction on where they might want to price a product to have it be designated as cost-effective. They're not currently routinely used in formulary decisions because part of the ICER challenge is that it does not include any type of rebates or other discounts that a plan may negotiate that would be factored into the finances. Well, certainly cost is embedded into all of our systems. The cost-effectiveness argument is a good one. Most plans do not have the internal expertise to be thinking about qualities or cost per life year and things of that nature. So I think it'll take a few years and perhaps some newer graduates from the pharmacy schools to work their way into the health plans to be able to drive this concept effectively. Currently, there's lots of resources in the marketplace, whether it's direct from the manufacturer, whether it's associations that may be publishing, whether it's physician organizations and groups, and also conferences like the Academy of Managed Care Pharmacy provide an excellent source of information and resource for plan pharmacy managers to keep up with the multiple sclerosis market. I think as pharmacy benefit managers, we need to strive to engage patients to take responsibility for their disease and medication therapy. We want to encourage them to be adherent with therapy, to take notice of changes in their individual health, and ultimately for all parties involved to get maximum value for the dollars we're spending on this category, which is in the top 3 of spend for specialty because of the number of patients and the high cost of the drugs in this category.